Endometrial hyperplasia occurs when the endometrial lining becomes abnormally thick due to prolonged exposure to estrogen without enough progesterone, a situation often referred to as unopposed estrogen. There are several causes for this hormonal imbalance. Perimenopause and menopause. During this time, ovulation becomes irregular or stops altogether. This results in a lack of progesterone production. Polycystic ovary syndrome. Women with PCOS often have infrequent or absent ovulation, leading to chronic estrogen stimulation. Obesity. Fat tissue can convert androgens into estrogen, increasing estrogen levels in the body. Estrogen therapy. Women on estrogen-only hormone replacement therapy, especially those who haven't had a hysterectomy, are at increased risk. The use of tamoxifen. This breast cancer medication has estrogen-like effects on the uterus. And finally, certain ovarian tumors, like granulosa cell tumors, may secrete estrogen and contribute to hyperplasia. Endometrial hyperplasia may not always cause symptoms, but when it does, the most common one is abnormal uterine bleeding. This can include heavy or prolonged menstrual periods, bleeding between periods, bleeding after menopause, or shorter than normal menstrual cycles. Diagnosing endometrial hyperplasia involves several steps. First, a thorough medical history and physical exam with special attention to menstrual patterns. Next, a transvaginal ultrasound is performed. This helps measure the thickness of the endometrium. In postmenopausal women, a thickness greater than 4 millimeters may require further testing. The most definitive test is an endometrial biopsy. This involves collecting a small sample of the uterine lining for examination under a microscope. Other methods include hysteroscopy, which allows direct visualization of the uterine cavity, and dilation and curettage when a larger tissue sample is needed. According to the World Health Organization, there are 4 types of endometrial hyperplasia: simple hyperplasia without atypia, complex hyperplasia without atypia, simple hyperplasia with atypia, and complex hyperplasia with atypia, which carries the highest risk of progressing to endometrial cancer. The term atypia refers to abnormal changes in the cells that may be a precursor to malignancy. Treatment depends on the type of hyperplasia and whether atypia is present. For cases without atypia, hormonal therapy with progestins is the standard treatment. These can be taken orally, injected, or delivered through an intrauterine device such as the levonorgestrel-releasing intrauterine device. Lifestyle changes like weight loss may also be recommended, especially in women with PCOS or obesity. In cases with atypia, treatment is more aggressive. A total hysterectomy is often advised for women who have completed childbearing due to the high risk of progression to cancer. For younger women who wish to preserve fertility, high-dose progestin therapy with close monitoring through repeat biopsies may be considered. If left untreated, endometrial hyperplasia can lead to endometrial cancer, especially in atypical cases. Persistent or worsening bleeding, which can cause anemia. Infertility, due to hormonal disruptions. And side effects from hormonal treatments, such as mood changes, weight gain, or breast tenderness. With timely and appropriate treatment, the outlook is generally good. Non-atypical hyperplasia often resolves completely. Atypical forms, if detected early, can also be managed effectively, significantly reducing the risk of developing cancer. If you found this video helpful, don't forget to like, share, and subscribe for more informative content. Stay tuned for our next video.